Good day. My name is Lori Harmon. I'm the Director of Quality at the Society of Critical Care Medicine. SCCM welcomes you to the Project Dispatch and SCCM Emergency Medicine Section's collaborative webcast, Understanding Brain Death, for laypersons, experts, and everyone in between. This webcast is a collaborative effort between the Society of Critical Care Medicine's Emergency Medicine Section and Project Dispatch. Funding for this project is provided by a grant from the Agency for Healthcare Research and Quality. Any views presented by the speakers in this webcast are those of the presenters. We welcome you to ask questions for our presenters throughout the webcast. You may do so by typing your questions into the question box in your GoToWebinar panel. Questions will be addressed after the presentation. You will also have the opportunity to participate in an interactive poll. When you see the poll, simply click the button next to your choice. This webcast will be available on YouTube the next business day. I will now turn the webcast over to our moderator, Dr. David Seder.
Hi there. This is Dave Seder. I'm the Director of Neurocritical Care at Maine Medical Center in Portland, Maine, and Assistant Professor of Medicine at Tufts University. I want to welcome you to our webcast today and our webinar. We have a great topic and a great speaker. It's Isaac Tawil from my alma mater, the University of New Mexico School of Medicine, where he is Associate Professor of Critical Care and Emergency Medicine and the Director of the Neurosciences Intensive Care Unit. So thanks again for joining us, and we're all looking forward to Dr. Tawil's presentation. At the end of the presentation, there'll be an opportunity to ask some questions. So we'll turn it over to Isaac now, and enjoy the webinar.
Great. Thanks so much, Dave. And first, I also want to start by thanking Society of Critical Care Medicine and Project Dispatch, which, as Lori mentioned, is an AHRQ-funded program, for the privilege of talking with you all about a topic of tremendous importance, understanding brain death. As you may know, Project Dispatch's goal is to disseminate patient-centered outcomes research and family-centered care to healthcare providers. And so today we're going to explore how to better be family partners and educators in the setting of brain death determination, and thereby improve care at the bedside during what we all know is a highly stressful time for family. I'd also like to mention that I have no conflicts of interest to disclose. Next slide. Okay, so first I want to first and foremost encourage listeners who are interested in this topic, if you haven't already heard it, check out SCCM's recent webcast on brain death determination by Drs. Greer and Provencio from a couple of weeks ago. You can access this talk in the SCCM store online, and it's an excellent detailed review on the history of brain death, the current determination process, and a discussion of specific controversies. If you have heard it, I hope it's also linked it nicely. But today, what I'd like to do is I'd like to examine brain death through the prism of the current level of understanding of this diagnosis and the concept, looking at the spectrum of understanding from laypersons to experts who determine death as part of their brain death as part of their routine clinical practice. Then what we're going to do is discuss a couple of key focused educational interventions for folks on both sides of the spectrum. We'll review some of the very fundamental concepts of the actual brain death evaluation, and then talk about some areas of important future study and research. I put this reminder on the bottom for myself to tell you that a lot of experts in brain death or death by neurologic criteria would assert that a lot of the misconceptions really come from the term brain death itself, because the term brain death for some implies that this is somehow qualitatively different than conventional death, or what we know of as a cardiopulmonary death, when of course that really couldn't be further from the truth. Death is a unitary phenomena. There's only one way to die, but of course in the modern era of mechanical ventilatory support, there has to be a different way of arriving at death determination, and that's why death by neurologic criteria is a much more appropriate and accurate description of the process. Of course, for myself, like I imagine for many of you, the term brain death has entered my medical vernacular, and so probably through the talk I'll be using these terms interchangeably, but I think we should all try to move from using the term death by neurologic criteria in lieu of brain death. So, next slide, please. So first I'd like to start by telling you a short story that happened to be early on after fellowship. I think I was in my first year as junior faculty here at UNM, and I was the attending on for the week. And One busy evening, a lot of trauma patients came in, including a very unfortunate case of an 18-year-old female who was ejected in a motor vehicle collision. She arrived to the resuscitation bay with an obvious devastating traumatic brain injury on CT imaging. It was diffuse in nature. She initially had a Glasgow Coma score of 1T1 with no evidence of brainstem reflexes, and this poor exam persisted throughout the resuscitation period over the ensuing hours. Other injuries were relatively minor compared to her devastating TBI. And it was apparent to the care team who communicated to the family that unfortunately there was no medical or surgical therapy that could be offered for this young girl. The family is obviously completely distraught. They're at the bedside, and the scenario doesn't look that much different than the cartoon pictograph that you see here. And to the family, the patient, their daughter, looked like every other patient in the ICU bay. Appears restful and sedated on the ventilator. The chest is rising and falling with every delivered breath. The same blips are on the monitor. And so it's confusing and troubling when the care team is communicating that there's nothing we have to offer for their daughter in this situation. Now, to make matters worse that night, someone from the care team communicated to the family that while the next step is to determine death by neurologic criteria, they weren't going to move on to that step until the family decided whether or not this patient would become an organ donor. And when I tell this story in front of live audiences, I hear many gasps, appropriately so, because this is tremendously problematic on so many levels, most important of which is all the care that we render to a patient, including the death determination, is never contingent upon someone's designation to be or to not to be an organ donor. And of course, there are many other problems with this scenario, not having a trained requester bringing up organ donation, the timing was all wrong. But as you can imagine, this served to really lose the trust of the family in a highly emotionally charged time. And when I came in the morning, I was working back from behind the 8 ball because the family was so angry and had lost such trust in the care team that they were insisting that their daughter be transferred to another hospital in town, when in all likelihood their daughter had already likely suffered death by neurologic criteria, which yet needed to be determined. So after much talking, I convinced the family to reluctantly allow me to do the brain death evaluation there at the bedside. And as you can imagine, the idea of politely asking the parents at this point to step out of the room and go to the consultation room, as was our typical practice, was going to be a complete non-starter. And so this was my first experience doing the brain death evaluation with concerned parents looking over my shoulder. And we went through the entire brain death evaluation in its entirety, going through every cranial nerve, all the cranial nerves exams, and explaining everything along the way, then on to the apnea test, disconnecting her from the ventilator. And 10 minutes into the test, as we're drawing blood gases, and all eyes are on the patient's chest, looking for any respiratory effort, Mom taps me on the shoulder, and with tears in her eyes says, "She's dead, isn't she?" And out of this horrible tragedy, really we were thankfully able to obtain the best possible outcome, which was we achieved the best closure for the family and allowed them to start the grieving process appropriately. And the family also consented on her behalf to be an organ donor, and she did off of the transplant waiting list. And that really spoke to me because I was certain that there were no words I could have used, there was no explanation I cocould have provided that it would have had the same impact to that family as being there throughout the entirety of the brain death evaluation. And so at the next possible moment that evening when I was able to get to a computer, I was really eager to search the medical literature and see what it had to say about two particular questions that were on my mind. Number one, what do we know about families in this situation and their level of understanding in this highly emotionally charged time? What do they understand about death by neurologic criteria? And number two, while I saw the merits anecdotally in front of my eyes, has a family presence strategy during the brain death evaluation ever been studied with any sort of scientific rigor, and has it been shown to improve any patient or family-centered metrics? And so I'd like to share with you some of the results of those questions. Well, you know, when you consult the literature, overwhelmingly, when you're inquiring about family understanding or layperson understanding of brain death, it's universally poor. And while that's probably not surprising to anybody listening, what was alarming was that in two of these references below, as many as 1/3 of relatives of patients diagnosed with brain death did not understand that death had truly occurred. And this is even after having discussions of organ donation and having the family members leave the hospital. They did not truly understand that this patient died in no uncertain terms. And the last of these four references actually tried to discriminate between family members who said that an explanation of brain death was provided for them, comparing them to family members who said that they got no such explanation, and even there they couldn't distinguish any difference, which demonstrates that even at times where we try to explain brain death, we do a suboptimal job at this. And even worse, not only are we potentially compromising their grief and closure in these circumstances, but we are also compromising the fallout, which involves their end-of-life care decisions, particularly that of organ donation. Because as we know, patient families are often consenting to organ donation now on patients' behalf without a clear understanding of death by neurologic criteria. And in this one study, they concluded that respondents who accepted that their loved one was truly dead when they were told that the patient was brain dead were much more likely to donate than those who did not consider the patient to be dead until mechanical ventilatory support was withdrawn and the heart had stopped. And here's another reference that, again, corroborated the association between the level of the family member's understanding of death by neurologic criteria and the likelihood that they would consent for organ donation, finding that the next of kin who decided against organ donation had far less understanding of brain death than those who were in favor of this donation. And the onus of these horrible conclusions is really on us as the educators. So the next obvious place we should look is, what do we as the experts, as the physicians and healthcare providers in the intensive care unit, how good is our understanding of brain death? Well, when you consult the literature about that, you find that, again, the results are suboptimal. Here's two such studies, one from JAMA in 1989, looking at only attending physicians, some of whom report that they encountered death by neurologic criteria in their practice. And then this was replicated with pediatric attendings a decade later in 99. And as you see in the JAMA study, only 63% of physicians correctly defined brain death as irreversible loss of brain function, and only 35% were able to correctly interpret a brain death scenario that was given to them. So if the expert's understanding is poor, we're talking about attending physicians here, why is that? Where is the root of this knowledge deficit? Well, the obvious next place to look is our medical education system. And are we teaching medical students death by neurologic criteria in an appropriate, effective fashion? And when you look at this, here's four such references. The answer there is we're not doing a good job. This first one looked at Ohio medical students, asking them questions about death by neurologic criteria as well as organ transplantation, and these students fared worse than a random layperson sample. This is not unique amongst U.S. medical students. There are similar findings in Hong Kong, where half of medical students were able to make a distinction between brain death and a persistent vegetative state, and similarly in Canadian medical students and Brazilian medical students. But one of the challenges or the caveats to all these studies is that at this point, there was never any validated assessment tool used to measure understanding of brain death. And this provides problems, particularly when you want to go to your curriculum committee and make additions and prove that what you're suggesting to add to the curriculum is effective. It would be much more useful to have a tool where you can measure the before and after. And so for us, this was the obvious next step to try to make a dent in medical student understanding of brain death. And in 2008, 2009, we set out to develop and validate the first tool for assessing and measuring one's understanding of brain death. Now, I won't belabor you with the process of making the assessment tool, but suffice it to say it went through several iterations of questions, and we wanted to make sure every one of the questions on a simple survey were validated for internal consistency. That is, do these questions actually ask and get at what we believe we're asking the respondents? These questions should all have test-retest validity, as well as, most importantly, discriminatory capacity, the ability to truly discriminate between someone who does and someone who does not understand death by neurologic criteria. And after several iterations of questions, we finally came up with a simple 5-item questionnaire that I'd like to share with you. Why don't we review this? It is 5 simple questions that you answer yes, no, or unsure to, and you're given 1 point for every correct answer, the answer unsure being marked as an incorrect answer. So number 1, can someone who is brain dead breathe without the support of the breathing machine? The answer to that being no. Number 2, can someone who is brain dead ever wake up or recover? The answer to that being no, getting to the irreversibility of a death by neurologic criteria. Number 3, will someone who is brain dead react? Will they grimace, move away, or blink if someone touches their eyeball? This gets at a couple of things, one being response to noxious stimulus, but also delves deeper into someone's understanding of cranial brainstem reflexes, and in particular the corneal reflex that needs to be absent here. Number 4, can a person be brain dead even if their heart is still beating? The answer being yes in the setting of mechanical cardiopulmonary support. And number 5, is brain death different from a coma or persistent vegetative state? Again, here the answer is yes. Now, armed with a measuring tool and this questionnaire, the first obvious place to use it was some low-hanging fruit, which is giving it to the student body at our own institution and evaluating how well do we do at the University of New Mexico in teaching brain death. And I can tell you, before we administered the survey to the student body, we thought we were doing a pretty good job teaching death by neurological at several points along the spectrum of medical education. What we did is we administered the survey to first years through fourth years at different times throughout their medical education, after which we would have expected that they would have been exposed to brain death teaching. So the first years got it right after they started, so they should approximate scores of lay people. And the second years after their preclinical neurosciences block, third years after their neurology rotation, and fourth years after their ICU rotation. And this is how they fared. It's a busy slide which breaks it down by individual question, but I would just focus on the red circles there, and that row demonstrates the percentage of each class and the entire group who scored a 5 of 5 and demonstrated complete expertise in understanding death by neurologic criteria. And what we see is that, unfortunately, overall, the student body, only 1/3 of them, were 33%, were able to get scores of 5. First year started at 18%. This improved by second years to 31%. Third years, there was a significant jump after their neurology rotation, but still well under 50% level of expert understanding. And fourth years, we're still graduating students where fewer than 50% on this survey tool can claim an expert understanding of the concept of brain death. And so the sum total of all the data that we've reviewed thus far is that we've got a lot of work to do to educate folks across the entire spectrum of medical education to understand death by neurologic criteria. We were able to use this tool to implement some useful educational interventions in our curriculum, and since have retested the student body, and we've improved their understanding, although whether or not this understanding is going to be lasting over years of their career obviously remains yet to be seen.
Isaac, these are really interesting and concerning data to me. The data suggests that both the public and physicians may not understand as much about brain death as I previously thought. And when I think about the great suffering that families are experiencing as they struggle dealing with the loss of a loved one and trying to understand how they may be able to mitigate the tragedy that they face, I can only imagine how stressful it must be when a family that doesn't really understand what brain death is being asked by physicians or organ procurement officers to consider the possibility of donation. For families that understand what brain death is, organ donation can be a source of comfort. It's a way for them to make some small good out of a terrible situation. And that comfort is lost to those who don't understand what they're being asked.
Absolutely.
I'm also troubled that there are graduating physicians that understand brain death so poorly. Physicians are supposed to serve as counselors to patients and to their families, and an understanding of brain death, although it's complicated, strikes me as a very basic tenet of the practice of medicine.
That's a great point, which is also, and we could talk about this later, but why I advocate for folks to understand that this is not something that should only be within the toolbox of a neurospecialist or an intensivist, because physicians and clinicians from every specialty can find themselves counseling patients on end-of-life issues that relate to death by neurologic criteria. Really, I believe everybody who graduates medical school or nursing school should be able to be an expert, at least in the understanding of the concept of brain death. And this is actually a great segue to move on to that second question that I asked myself that night, which is, has a family presence strategy during the brain death evaluation ever been studied or shown to improve understanding? And before we go into some of the literature, what I'd like to do is poll the audience. And if you can click on an answer, what we'd like to see is, and I'm not asking about you personally, but rather in the ICU that you're affiliated with, are you always offering family presence during the brain death evaluation? Sometimes hovering around plus or minus 50%, depending on the practitioner, the day, rarely less than 25%, or never. So I'll give you a few seconds to answer this, and we'll see what the responses are. Okay, well, it looks like I'm reassured that looks like at least a third of folks are doing this at least 50% of the time, and I hope I make a dent and can convince you with the following data that this is something worth looking into for your particular institution. So back to family presence. As many of you who are already listening know, and actually this was already addressed on one of the Project Dispatch webinars, the idea of family presence during a whole host of scenarios where typically we thought that would be too stressful or inappropriate for family members to be present, it turns out there is a growing body of robust literature demonstrating merits of family member presence during a whole host of scenarios, including invasive procedures, resuscitations, and that includes CPR and medical resuscitations, trauma resuscitations, and the like. And they've found the merits are numerous, including decreased feelings of helplessness amongst the families. They're more engaged in the scenario. It could mitigate grief and facilitate closure in the setting of someone's demise, and also help family members really understand the gravity of the situation at hand that the healthcare team is dealing with. Here are 5 such references, 3 of which also dispelled the notion that this may be at the expense of psychological distress for these family members, and they found out that they fare no worse on follow-up after randomization. And similarly, they also dispelled a lot of the myths that have been perpetuated, such that there might be increased litigation or that family members may be disruptive to the care process, and these thus far have been pretty debunked by the body of literature. But when you look at the literature, at least historically, on family presence during the brain death evaluation, it wasn't as robust. There were certainly plenty of advocates in the literature for family member presence, but the nature of the evidence was more editorials and observational studies saying, you know, we practice this in our units and we think it works well. Family members seem to like it. There was one survey study down here where they surveyed neuro ICUs across the UK, and again, folks were advocates of it, but there was never any rigorous data to dispel the myths of the skeptics. There was this recent failed trial where they stopped the trial after enrolling just a couple of study subjects, but even then the authors advocated for a family presence strategy. So now, armed with this measuring tool, the obvious next step for our group was to try to do that PRCT at our institution. And so over 2009 through 2011, we performed a prospective randomized controlled trial of family member presence during the brain death evaluation. And I'd like to share how that went with you all and what we found. And so we set out to enroll only immediate family members of patients who were suspected to be dead by neurologic criteria. So once we knew that the next step was to embark on the brain death evaluation, we then group randomized only immediate family members, up to 5 of them, to either presence versus absence during this evaluation. So it's important to note that they were group randomized. We never separated out siblings or parents and other family members, some to be relegated to absence versus presence. They were all randomized as a group. And the primary outcome measure that we sought to evaluate was the level of understanding of brain death using our survey tool pre- and post-intervention. And the secondary outcome was to measure their levels of psychological distress at 1-month follow-up. This is what the study protocol looked like for randomization. It was at this point where they had their first contact with the family care chaperone and family care coordinator, who was going to walk them through the entire process. And then they started by completing the survey for the first time. And then they were randomized as a group to either family member presence versus absence. And it's important for me to point out here that we weren't truly just testing presence versus absence, and rather the study intervention was what we were really testing was a holistic educational intervention at a teachable moment. So it wasn't simply that the family was sitting there in the corner of the room watching what was going on, but rather there was a dedicated educator for them, and the person doing the brain death evaluation was going through each step along the way, explaining what they were doing and the significance of what they were finding or not finding with each of the steps of the brain death evaluation, including the apnea test. Similarly, the family who was relegated to the control arm, the idea wasn't to keep them in the dark. we're trying to approximate what was the standard of care. So we would ask them to hang out in the consultation room. They were also provided a family care coordinator who was there to make sure that any of their questions about anything, including the brain death determination process and what brain death meant, answer those questions for them. Then, of course, after the brain death evaluation was completed, the family members then completed the second survey. Then, as was our typical practice, and only after death by neurologic criteria was determined in its entirety did we have any discussions about organ donation using trained requesters. And then between 1 and 3 months later, we administered a couple of psychological evaluations as their follow-up metric. And here are some of the results that I'd like to share with you. We were able to randomize up to 58 family members that pertain to 17 brain death evaluations. Remember, you can have 5 subjects per brain death evaluation. 38 were randomized to the presence arm, 20 to the absent arm. As you can imagine, there were families who were unable to participate, and we sought to find out why. There were 12 such families. 8 of them insisted on being present. Once they found that this could be an option, they said, Dr. Tawil, wow, we would absolutely not want to be there. This sounds really important. We would respectfully decline to be in the study because we don't want to be randomized to the absent arm. And similarly, not everybody felt that way, but we had 4 families who insisted on absence. And for that reason, they felt it was too stressful. They didn't want to take the chance of being randomized to be in the room, and so they also declined. And we were able to get decent follow-up at 1 month of 71% on all these subjects. So looking at some of the results further. This is a box plot looking at the pre and post understanding brain death scores. What you see on the left is the box plots of the medians and the spread around the medians for how folks scored before the intervention. As you can see, they scored as we would expect laypersons would, with medians between 2 and 3. And of course, after the intervention, there was a significant difference between those randomized to presence versus absence. Significantly higher understanding brain death scores in those who were randomized to the present arm, as well as the relative change in understanding between pre and post-test were statistically different. Another way at looking at this data is looking at the mean scores amongst those who were randomized to present. Their mean score was 4.4 versus 2.8 in the absent arm. Also, the relative change in understanding was statistically significantly different. What wasn't different between groups were the follow-up psychological evaluation metrics. These folks were administered 2 psychological examinations. One, the IES, which is the impact of event scale, that gets at different components of post-traumatic distress, both intrusion of thoughts and avoidance of thoughts that might remind them of the brain death evaluation process. Those weren't different among groups. And similarly, the general health questionnaire, the GHQ-12, which gets at the overall psychological well-being, grief, depression, and anxiety, those scores didn't differ between 2 groups. Some more results. The number of achieving expert scores, those who scored 5 of 5 on the understanding brain death evaluation, made up 66% of those who were randomized to presence and 20% in the absence group. And I think as valuable, if not more valuable, than some of the quantitative results, but qualitatively, we polled the folks who were present in the room, and 95% of them, of those folks, thought that being present helped them understand brain death, regardless of what they scored on the test. And I think that's of significant importance. And 84% reported that they would recommend presence to other family members who found themselves in this situation. Now, I think it's important to take a break and just talk about a few of the components that I thought, and a lot of the investigators thought, that really were key to the success of this family intervention and bringing this to your institution. One, we all know that this really should be family preference. No one is forcing any family member to be part of the care process, but they should be offered the opportunity, we believe. What was really key to the success of this strategy was a clinician chaperone who was dedicated to nothing else but the family's education and the family well-being. And this person had to be completely separate from anybody who was part of the care process for the patient. So, you want the physician doing the brain death evaluation to be completely focused on that brain death evaluation. Similarly, for the nurse, respiratory therapist, any other ancillary staff who are helping make this happen, they have to be able to be focused on things such as all eyes on the chest during the apnea exam, or running the blood gases at the appropriate time. And so there really has to be the resource that is dedicated to nothing else but the family well-being and their education to make this work. Also, particularly in an academic center such as ours, it's important that the clinician performing them is not only experienced, which we would expect from anybody in any hospital doing the brain death evaluation, that they have experience with this, but also that they're prepared for family presence in this situation and really prepared to deal with any unanticipated consequences, such as spinal reflexes occurring during the exam, having to abort the apnea test, or determining that, in fact, the patient is not dead, as the care team suspected, by neurologic criteria. So you want a confident family practitioner that can handle those situations when there's a family around. And also, you may have to limit the number of family members, as we did. We did this for a couple of reasons. One, we figured that the educational efficacy would be diluted the more patients we were trying to teach, as this was really testing an educational intervention. And we were also limited by space in the ICU bays, and so that's why we kept it to 5. And that was an arbitrary number, and you may find it works with fewer or more in your particular setting. And lastly, and this is no different than really any scenario in healthcare, but particularly when we're talking about explaining and teaching death by neurologic criteria, it's really important that we understand their level of education and be sensitive to particular educational barriers, language and cultural differences, and perceptions of death in general and death by neurologic criteria. And so in conclusion, family member presence at the bedside during the brain death evaluation does increase the family member's understanding of brain death without apparently increasing their risk of emotional or psychological distress. Now, the effect of family member presence during the brain death eval on consent for organ donation remains to be determined. While I'd like to believe that improving their understanding will have the secondary effect of facilitating consent on behalf of the patient for organ donation, really you need a multi-center endeavor and several hundred folks in such a trial to really demonstrate this outcome, particularly now in an era where many people already come to the hospital with first-person donor designation from donor registries or driver's license and such. But for me, frankly, and I hope for you, I think that just the metric that we know that we can increase the family members' understanding before they leave the hospital and understanding of death by neurologic criteria before we have discussions about organ donation, for me, that's a game changer in and of itself. And I would hope for you as well.
So I have to admit, when you first described the research you were doing to me, it was probably 5 years ago now. It took me a while to understand why families might want to be present for such a morbid and difficult examination. But actually, since you published this research in critical care medicine, I've begun to involve families in the brain death determination process more directly. And I've found some family members don't want to watch the brain death examination, but a surprising number, especially those who are confused about what brain death means, they want to be present for the brain death exam. And I've had experiences similar to what you described at the beginning of this presentation, in which parents and other family members came to terms with the terrible reality of death by neurological criteria only while observing the brain death exam, and really especially the apnea testing. Of all the elements of brain death testing, when a family sees a person not breathing for a period of 8 to 12 minutes, I think the reality of their death is much easier to understand than when they appear to be breathing through the ventilator. I applaud the completion of this unlikely study, which has really directly changed my own practice in the area for the better, I think.
Thanks, Dave. And I could tell you, we anecdotally, I see the same thing, which is the light bulb really goes off during the apnea test. I think that is really telling to someone who had even anybody who has no medical exposure or background at that time. I bombarded folks with the literature, but if you need any other convincing that we need to be better educators of the lay public on death by neurologic criteria, this is really further demonstrated by cases that we hear about not infrequently in the media. And these are just a couple of the media clips highlighting the tragedy of the death of a young child. You probably heard of this case in 2013, where the brain death evaluation was sound and not in question, but followed by a really complicated course where the family wouldn't accept death by neurologic criteria. Now, this recently publicized case highlights some other controversies and demonstrates how we in the healthcare community can actually perpetuate some confusion, as in this case, tracheostomy and gastrostomy tube was performed ultimately on a child who was pronounced dead. And lastly, it's an example that it also demonstrates how the media can confuse folks by discussing this case of death by neurologic criteria in the context of other cases, like the controversial case of a patient in a persistent vegetative state. And this happened both in the print media that you see here as well as in television media. And of course, these situations are completely different scenarios, but to the typical layperson observer, it is really confusing, and it blurs the line between a coma and a persistent vegetative state and that of death by neurologic criteria. And so it's in that spirit that I'd really just like to review the very fundamentals, the basics of the clinical brain death evaluation. And again, I would also like to refer you to the specifics of the exam to go check out the recent SCCM webcast that does a detailed review of the process. But just briefly, of course, you wouldn't even embark on brain death evaluation until you were certain that there was clinical and neuroimaging evidence of acute CNS catastrophe that is completely compatible with a diagnosis of death by neurologic criteria. Otherwise, you just certainly wouldn't move forward. And then, of course, then the next step is you have to exclude any complicating medical conditions that can possibly confound the clinical assessment in any way. So you have to exclude severe electrolyte, acid-base, and endocrine disorders, and make sure any shocks are dealt with. You also have to exclude any drug intoxication or poisonings, including the medicines that we administer, neuromuscular blockade, of course, and any sedatives. And we have to exclude hypothermia, making sure that their core temperature is at least 36 degrees. Then at that point, if all the prerequisites are met, then we can move on to assessing the 3 cardinal findings of brain death, which is number 1, determining coma and unresponsiveness, number 2, the absence of all brainstem reflexes, and number 3, apnea testing without a respiratory response to a potent hypercapnic stimulus. And going through each of those briefly, so coma and unresponsiveness, cardinal finding number 1, we're going to prove the absence of response to noxious stimuli. That's both loud verbal stimulus, including both peripheral tactile and central tactile stimulus that can be nail bed pressure and supraorbital pressure that should evoke a response. Any cerebrally mediated response, including extension reflection, means this patient is not dead by neurologic criteria. That being said, there may be spinal reflexes that can remain intact. Sometimes these are tough to discern, and you got to get some more expertise to the bedside. But if they are in fact spinal reflexes, spinally mediated reflexes, those do not rule out the diagnosis of brain death. Once you've assessed cardinal finding number 1, and there's coma and unresponsiveness, then you move on to number 2, the absence of any brainstem reflexes. Just briefly through them, the pupillary light reflex, the corneal reflex, gag and cough reflex, the doll's eyes or oculocephalics, and your cold calorics, making sure the vestibulo-ocular reflex is also absent. Then and only then would you move on to cardinal finding 3, the apnea test. And similarly to determining the fitness of someone for brain death evaluation, you then first have to assess the patient's fitness to be disconnected from the ventilator without significant deterioration. And so the patient, in order to do the apnea test, has to meet another set of prerequisites. Or body temperature has to be in order 36 degrees. Systolic blood pressure should be at least 100. Vasopressor is acceptable. Patient should be euvolemic. PaO2 and PCO2 within the normal range for that patient. The patient should have a relatively normal pH, as we're going to make them hypercapnic with a respiratory acidosis, and not requiring high FiO2s or mean airway pressures, as those patients will likely not tolerate being disconnected from positive pressure ventilation. To perform the apnea test briefly, we set the ventilator to obtain a PCO2 within the normal limits for that patient. We pre-oxygenate them. We then disconnect them from the ventilator circuit, passively oxygenating them with a nasal cannula through the ET tube with the cuff down. The patient's PCO2 is then allowed to rise to at least 60 millimeters of mercury, or 20 above their baseline if it's higher than 40. And a diagnosis of brain death is supported if there's no respiratory effort. So all eyes have to be on the chest without a gown on it, no respiratory effort. Now, this is primarily a clinical diagnosis. This is a clinical exam that does not typically require any imaging or ancillary studies unless the clinical exam is at all equivocal or any component of this exam cannot be completed in its entirety. So common scenarios are where the patient's not going to tolerate disconnecting from the ventilator circuit, and so you can't complete the apnea test. You would have to move on to add an ancillary test in addition of the clinical exam that you can perform. Similarly, another common scenario is severe facial trauma, obviating testing some of the cranial nerve reflexes. You'd move on to an ancillary study as well in addition. And this can include a whole host of studies, including cerebral angiography, nuclear imaging studies, TCDs, CTA and MRA, a bit more controversial, and EEG monitoring. And it depends on the resources of your institution and what you guys have decided as an institution, and the AAN allows for most of the guidelines, which we will go into. Because now that we've reviewed that there, the fundamentals of the brain death evaluation, you might be surprised to know that there is some logistical variation in the brain death evaluation protocols across the country. And this was demonstrated really nicely in this paper by Dr. Greer and colleagues in 2008, published in Neurology, where they simply compared brain death determination guidelines from the top 50 U.S. neurologic centers, looking for differences between the guidelines themselves and between the guidelines that were submitted and the AAN guidelines, the American Academy of Neurology guidelines, which at the time, the most recent set of guidelines were the 1995 guidelines. And they received an 82% response rate, so they evaluated 41 sets of guidelines, and they compared them in several categories, and I'd like to just review the results briefly. For number one, they evaluated them on guideline performance, that is the logistics of who's doing these exams. And you can see there's a lot of variation, probably depending on the institution. In some institutions it had to be an attending, some allowed for residents. In terms of what specialties did the brain death evaluation, kind of all over the board. Some relegated it to neurological specialties or intensive care, whereas in other settings it could have been the general practitioner who admits the patient, surgeon, internist, pediatrician, what have you. Also, what was different is the number of exams that were required on these different sets of brain death guidelines, or protocols, rather. Some had one exam, some had one confirmatory exam. The time frame between the exams also differed. So these are really opportunities to perhaps settle on what might constitute best practice, which also there may be best practice depending on the institution that you're in. Similarly, there were differences in the prerequisites for testing that you see here. Not everyone explicitly mentioned each one of these prerequisites in their set of protocols, but even another variation was the parameters that were set for these various prerequisites. For example, while most of the guidelines called for hypothermia being absent and excluding shock states, they were all over the map in terms of what the core body temperature should be and what the minimum blood pressure should be. And since then, which we'll talk about, the AAN has really tightened up some of these parameters. But at the time, in 2008, there was also some differences in some of the clinical exam maneuvers that were discussed in these. Like, for example, you see here on the left bottom, some required the jaw jerk reflex. Does that add anything if you're testing the same cranial nerves through other tests? Not entirely sure. And similarly, there were some subtle differences with techniques of apnea testing. Now, as you can imagine, many of these details are not necessarily going to be answered by evidence-based medicine, but there are probably others where more study of various exam nuances may actually allow for the establishment of what we might consider best practice, and this would serve to further strengthen the integrity of the death by neurologic criteria determination process. And in 2010, the American Academy of Neurology sought to do just that and improve upon the 1995 guidelines. And like I said, they tightened up some of the parameters. They explicitly provided blood pressure and core body temperature prerequisite parameters of SBP of 100 and a core temp of 36. They also provided a really useful checklist with all the prerequisites and all the exam components to be used at the bedside, which I'm a huge advocate for. I think this should be done everywhere. But this update also highlighted the dearth of evidence to guide resolving some of the other discrepancies that we described earlier. And when they looked at the available evidence over the previous 15 years for a series of questions, this is what they were able to finally conclude. Looking at the evidence during that time period, they were able to conclude that in adults there were no published cases of return of neurologic function where the 95 AAN guidelines were strictly followed. They were able to assert that complex motor movements, particularly spinal reflexes we're talking about, and false ventilator autocycling did occur in the neurologic criteria, and so we have to be on guard for those and be able to work through those and discern them. those confounders. And, but they were also unable to provide any strong evidence to guide a minimal observation period or serial exams. And similarly, there was insufficient evidence to guide specifics of the apnea testing technique or evidence to guide whether or not we should be using certain new ancillary tests to supplement the clinical exam. And so we do have a lot of work to do over the next few years to try to shore up some of these questions. But I'd like to think that one thing we do know now is that all families should be offered the opportunity to be present during the brain death evaluation, and we have to see our job as being educators and not in addition to being expert clinicians in this circumstance. And as was said, I thought really eloquently over a decade ago by Doran and colleagues in critical care nursing, it is no longer acceptable for doctors and nurses to have the benefit of witnessing confirmation death while expecting relatives to accept brain death in the face of so much apparent life. And with that, I want to thank you for your attention and turn it over to Dave Seder.
Isaac, thank you so much for that excellent and provocative presentation. I did have the opportunity to listen to and participate in Dr. Greer and Prevencio's webinar a few weeks ago, and I really think this is a perfect accompaniment to that by offering a family-centered and family-focused approach to brain death determination. So I want to ask our audience to take advantage of having you on the line to answer questions they may have or just to share their own thoughts by typing in a question or a comment. I'll start things off by backing up to the beginning of the presentation and ask your opinion of how should we approach medical education around brain death? Why are we doing so poorly? And how can we assure that graduating medical students and residents have knowledge that they need to be expert counselors to families in a very difficult time? As you've pointed out, a few ill-considered words to families during the brain death determination process can create terrible and tragic misunderstandings.
Yeah, that's a great question, and I think I touched a little upon this. I think first, in terms of medical education, first I think we need to start by dispelling the notion that understanding brain death is relegated to certain specialties like neuro subspecialties and critical care medicine, for example. While in your institution, the actual determination process may be relegated to a specific specialty, and that's understandable. Everybody, no matter what specialty, inpatient or outpatient medicine, nursing, medical school, really should have an expert understanding of the concept of death by neurologic criteria. I think, none of us would think it would be acceptable for someone to graduate medical school or nursing school, for example, and not know the difference between life and that the pulse has to be absent and the patient can't be breathing. I think everybody would expect that. And I think in 2015, I think in the era where, the end game has changed for a lot of other catastrophic neurological and other events for patients, since more and more patients are finding themselves in intensive care units on the ventilator, I think an understanding of death by neurologic criteria should really be germane throughout medical specialties. Starting with that, I think in terms of the actual in terms of the educational intervention, while I don't claim any expertise in education science, what we found is that hands-on things like sim lab experience, which I know is happening around the country for many things, including brain death evaluation, is really useful and effective. We instituted video. We have a video tutorial that's available in all the ICUs for residents in training and anybody to watch in the setting of a patient who finds themselves ready to be determined dead by neurologic or undergo the brain death evaluation, rather. And we've also added components in medical education along the way. We have a specific brain death evaluation tutorial that every medical student takes between their preclinical and their clinical years at UNM. And then I guess the last thing I want to say is you touched on wording. We cannot underestimate the importance of using the right wording, and that's why Dr. Greer and Prevencio also talked about the same thing. What I advocate for is doing away with all euphemisms like the patient has passed on, or you think they're moving on, and I don't even use when I talk to the family about what I think is going on. Even when they're on the ventilator before the brain death evaluation, I say we suspect that your loved one has died. We suspect that they are dead. Now, of course, that's often gets some raised eyebrows because there's misunderstanding there, but that leaves me open to explain death by neurologic criteria instead of using the term brain death. And similarly, I avoid the term life support. So when after determining death by neurologic criteria, and the patient, and if someone says, well, how long are they going to be on life support, I make sure to interject that this is organ support. This is not life support. This is just a breathing machine.
So those are great pieces of advice, Isaac. We have a spectacular list of questions here. So I'm going to run through some of them and ask you to be concise if you can, just because I want to get through as many as we can. The first question came in toward the beginning of the talk, and it regarded your study that looked at the first, second, third, and fourth year medical students and their poor performance in terms of achieving expertise in understanding brain death. The question was whether there was a statistical difference between the results of the third and fourth year medical students.
That was not statistically different between the third and fourth years. No.
All right. The second question is actually a comment. It says it's from someone who signed off the conference, and it says, this is really just a comment. We find that similar findings occur when families are allowed to witness their loved one's cardiac resuscitation efforts in the ICU. Families tend to call off our efforts as they realize the efforts may be futile.
Yeah, look, we find that in the setting of death by neurologic criteria, it dispels a whole bunch of misconceptions about what's been going on with this patient. Obviously very different from the cardiac arrest scenario, but similar results in terms of enlightening family members.
Yeah. Okay, here's a question about what are the pros and cons of performing the apnea exam with the patient on CPAP with no breaths administered. And then it says recommend that that all institutions use a brain death checklist, and that document becomes part of the patient's medical record.
Right. I think we do all of our apnea tests off the completely disconnected from the ventilator circuit. I'm aware of other centers that do use CPAP, and I imagine that the potential advantage is that they don't go through the de-recruitment process, and they're less likely to deteriorate from hypoxia. When looking at the evidence, as you heard from the most recent review from the American Academy of Neurology, they couldn't comment on one way being superior than another, although I'm pretty sure they recommend disconnection from the ventilator circuit. And then when you bring in then the potential confounder of false ventilator autocycling, that's another potential disadvantage to being on the ventilator and having a machine pick up something that was not truly respiratory effort. Rather, we prefer to trust our eyes. They're focused on the chest through the duration of the apnea test.
Yeah, I completely agree with that. I think everyone has seen the strength of the heartbeat alone trigger the ventilator if the trigger sensor is set too low. Right. And the last thing you want is for people to think that the patient can still breathe when they can't. So it's a big drawback to having the patient on CPAP. On the other hand, you do avoid the de-recruitment issue so that you can maintain oxygenation better.
Right.
We as you do, we do all our exams off the ventilator.
Right.
Okay, you have a comment thanking you from the critical care fellows in surgical and anesthesia critical care at Northwestern. And then the next question said, would hospice nurses or physicians be the optimal family counselors, and should they be present during the brain death protocol?
I guess I'm a believer that I don't think it's the specialty that matters, and who, what I mean. I think it's a matter of what you bring to the table in terms of expertise. We had, for example, our experts. Family care coordinators who were there chaperoning the family and explaining, some intricate questions about death by neurologic criteria. They were from a host of different backgrounds. Some were respiratory therapists, some were nurses who had been critical care nurses before. Some were physicians. So I think it matters. And could it be a palliative care specialist? Absolutely. Any end-of-life care expert would be a great addition component to this process. And I think it's like a trained requester. I don't think a trained requester has to be someone necessarily from the OPO. It has to be someone who's savvy and truly has some training and expertise and mileage on this topic.
So that brings to a similar question, which is, have you run into issues being a non-neurologist in training in formal declaration of brain death?
No, I haven't, and my perception is that this is really part of the skill set of any intensivist. I mean, this is where death by neurologic criteria happens and is determined most often. I have never been, the integrity of my brain death evaluations have never been questioned, because of what specialty I come from. And I think it's more what do you bring to the table at that point in time in terms of expertise. And I know neurologists who, as part of their practice, rarely, if ever, do death by neurologic criteria. And I also know some general practitioners who, in community hospitals with no neurology background training, but this is a part of their skill set.
I just qualify that, Isaac. I agree completely that really it has mostly to do with expertise and experience. But I do think it's important that the brain death examiner be experienced and expert because of, especially if you're going to have family members in the room, because it's very important, especially if people start to exhibit spinal reflexes or if they're not brain dead or if other things come up. I think if the examiner demonstrates any lack of expertise, that is potentially a big problem later on.
Absolutely, and I think what you find is the more, quote, expert you are and the more mileage you have, the more humbled you have been over the many years that you've been doing this, and are more willing to say there's some component I'm uncomfortable with or I don't understand, and we have to go the next step to further clarify this.
So I know we're going to get cut off in just a minute here. There are still a dozen outstanding questions that haven't been answered, and I can certainly make sure those get forwarded to Dr. Tawil. But Lori and Samantha, do we still have a minute or two, or are we just about done here?
Oh, please go ahead and ask maybe another 2 questions, and then we can close.
All right, I have a comment from a physician who says that he's created an interprofessional brain death simulation that puts medical students in the position of determining brain death and then puts them with chaplain resident together to deliver the news to a family member. I think that
sounds like a novel approach. Yeah.
Yeah, that's outstanding.
And I at least online and and through folks like SCCM, Neurocritical Care Society, I know that a bunch of different institutions are making are addressing the knowledge deficits with things like simulation programs and courses that you can take and all sorts of great approaches to this.
Okay, and then my friend Ryan wants to know, how do you think centers that use MRA or CT angiography as an ancillary test can continue to do so in light of the 2010 AAN guidelines? That's a kind of a controversial, a quagmire of a question. I'm not sure I have the. It seems like more of a comment than a question, but I think a lot of this highlights the need for further research, and I think and even the AAN acknowledges that there are still questions to be answered and room for a lot more study. And so I'd advocate for anybody listening involved in, who's at all interested in research to take on one of these questions and try to make an impact. I'm going to also add to that answer that just like the brain death examiner needs to be expert, the performance of these studies needs to be expert if it's going to be used as an ancillary brain death test. CT angiography as an example, if the contrast bolus isn't protocolized properly or timed properly, the results are not valid. But if you're at a center where the quality of those studies are excellent and the timing is good, then they're pretty reliable. And
right.
I think
what do you guys use as your ancillary test?
We typically use formal cerebral angiography performed by a radiologist. But I've had CT angiograms performed on patients with aneurysmal subarachnoid hemorrhage who came in with a brain death exam, and they came in with subarachnoid brain dead exam. They came in with CT with a subarachnoid hemorrhage obvious on their CT scan. They underwent CT angiography to look for aneurysm, and what was seen instead was a complete and total absence of flow. And in those patients, it's not unreasonable to think that might serve as an ancillary test, but it's not my go-to test. No way.
Right. Good.
Well, thank you both very much for sharing your expertise with us today. It's greatly appreciated. For the audience, we'll remind you that this webcast will be available on YouTube the next business day, so please feel free to use it, share it with your teams, and explore some of the content that we may have gone over quickly that you'd like to pick up on and use. So thank you very much to all, and have a pleasant day.
Thanks, Lori.